Good morning. In my language, Boreda, and in your language, what is good morning? Very good. First of all, I want to thank you for inviting me here. It's wonderful to be here, such a beautiful theater, and it's my first time in South Korea, in Seoul. I want to thank Professor Yu. He is now known to me as Sang-ho, or Karma Boy, actually. So we have had great meals and a great friendship already. So thank you very much for asking me to come here and to talk to you all. And a special thanks to Minji Kim, too, for doing so much organization of my travel and so on. Thank you very much. All right. I am here to talk to you about shared decision-making. Can I check, first of all, do you hear me well? Okay, good. I have seen the palace, and I have seen a Buddhist temple, and I have actually made soju already. So I have enjoyed my time here one day already, 2 days now. It's my third day. So thank you very much. First of all, I'm going to tell you a little bit about me. Who am I? So, first of all, when I went to university, I did theater and drama and the Welsh language. The Welsh language is a very old language from the 5th century. It's a Celtic language. It belongs to Breton and Cornish, although Cornish has died now. It's related to Scots Gaelic and Irish Gaelic. Around 500,000 people speak Welsh in Wales, which is less than a district in Seoul, right? It's a small place. After that, I did medicine in Cardiff in Wales. And after that, I did a PhD in the Netherlands on shared decision-making, actually on developing a measure option 12, observer option 12. That was my PhD. I have worked in Africa, in the Netherlands, and now I work in the United States in a university called Dartmouth College. I have had relationships with professors and researchers in different universities, in Switzerland and especially the Netherlands, and also now in London. With my colleagues, Natalie Joseph Williams and Adrian Edwards, I edited this book, the textbook of shared decision-making that Oxford is publishing. When I grow up near this mountain. It's a very high mountain, relatively high, but actually it's a very dangerous mountain too. Many people die in the winter when they go up not prepared for the ice and the snow. It's called Travan. I'm going to come back to this mountain in a little bit. First of all, I want to take you to 1962. It was a very, very tough winter. This is probably one of the scenes in the winter in 1962 in Britain, in the United Kingdom. And this probably was the kind of night when my mother found that my father was not very well. And she walked about a few miles to find a telephone. We didn't have mobiles, right? We didn't have a phone in the house. And she called the doctor. And the doctor took about 2 hours, I think, to come because he lives far away. My father had died of a myocardial infarct. So this was my first encounter with healthcare. And the family doctor was a very kind, very respected man in the community. People looked up to him. So I think, that's a very good job. And so it kind of sparked an interest in me as to, I wonder what it's like to be a clinician, a family doctor. And as you know, maybe, I am a family doctor now. I trained in family medicine. I have worked in Africa too, in a place where apartheid was still functioning in the 1980s. A very difficult period in South Africa. And I met children like this who were in a very poor situation, short of water, sometimes short of food. This is the health centre where I work in Cardiff, in Wales. It was called the Butetown Health Centre. Cardiff, in the turn of the century, was one of the busiest exporters of coal. South Wales is full of coal and full of steel. And many people from Somalia and the West Indies came to live in this part of Cardiff. So I had a health centre, a family practice, like a polyclinic, here in this health centre in Butetown. I tended to look after people who were homeless or were on drugs. So it was a tough place. It was underneath the railway. You know, have those places in Seoul where poor people live underneath the railway? This was the kind of situation that I was in practice. And people lived in these kind of houses. Cardiff, between 1850 and 1900, grew very quickly. Lots of people came to work in the coal industry and the mining industry. So you had rows and rows of houses like this. Massive influx of population. Not as big as Seoul. I would say 500,000 people lived in Cardiff. Still a big city for Wales, but not as big as Seoul. And so I looked up what shared decision-making in clinical practice here, and I'm told by Minji that this is a very bad translation. It's what Google could do. I'm sorry about that. I'm sure you could improve on it. Okay. Now I use this cartoon quite a bit, and maybe some of you have seen it before. It's an illustration of a medical visit. I'm sure many of you have been to medical visits, a medical consultation. What I would like you to do now in your mind is to imagine what this man in this medical visit is saying. What is he saying? What are the words that fit into the speech bubble? Maybe you could write it down, or maybe think about it right now. Can you do that? Take a moment. Maybe talk to your neighbor. How about that? Talk to your neighbor and say, what is he saying? Can you do that just for 1 minute? Turn around if you want to. Talk to your neighbor. What does he say? What does he say? What do you think he's saying? Does anybody have any suggestions for me, what he's saying? Who is brave to speak? I will make eye contact with you. What do you think he's saying? What is this man saying? Let us think about this?
Yes.
Okay. Anybody else? Who would like to say what he's saying? What's he saying? I have a lot of agenda. Yeah? Okay. Anybody else? I have a lot of patience. I will wait. What's he saying? You have a suggestion?
First, maybe He'll introduce himself.
Introduce himself.
Yes,
Okay.
and then
What does he say? Who is he?
yes, and then
Who is he?
maybe I'm I don't know about that.
Anybody else? Here? Yes. Okay. Very good. What's he saying?
I guess he's saying, hey, you have this disease, so you should take this medication.
Okay. So you have this disease. Anybody else? Hands up. Anybody want to speak? Very good. Thank you.
Maybe my recommendation is something.
Yeah, my recommendation is. So you know, this is what happens when I ask people to put words in this man's mouth. This is what people say. This is my agenda. You have this disease. This is my recommendation. I have bad news for you. These are your results. Right? And then I show the next slide. Who is this then? Who is this speaking? No. It's the who said patient? Who said patient? You said patient? You did, yes? Yes, it is the patient. You're absolutely right. What did most of you think? Most of you thought it was the doctor. Why did you think he was the doctor? Why did you think he was the doctor? Because of paper and pen. Maybe because he's a man? Maybe. Maybe. But he has a paper and pen, and what else? What else made you think he was a doctor? What did you say?
Doctors used to take that role. From my perspective, in many situations, I've heard that doctors they are likely to tell, I prefer this option, this is for you, you should take this, take that. So, yeah, that's
right. Yes, you're absolutely right. They take control, right? And they are the powerful person in the room, right? Exactly. So in almost every audience that I have asked this question, this is what people say. And then I say to them, if only I had 2 slides to summarize what shared decision-making is, I would use these 2 slides. Because I have another question for you, which is a much more difficult question. Ready? What did this clinician do to help him say those 4 words? Who is the clinician? Who is the clinician? No. The woman. The woman is the clinician. She is the clinician, the doctor. Because the man is the patient. So the question that is quite difficult, what did the woman do to help the man say those 4 words? Who wants to speak? I know it's your second language, English. It's also my second language, right? I learned English when I was 9, but I understand it's difficult. But what did that woman do? Any suggestions? Go on.
listening.
She was listening. Yeah. Yes, that's right. She was listening. What else do you think she did?
Asking what his life is goal. Yeah, what does he want?
She asked him, what does he want?
Yeah.
What does he prefer, right? Because he answered the question, oh, I prefer this. So what did she do before asking that question?
It seems like she has provided multiple options. That's why, yeah, he's in trouble. The patient is in trouble.
Exactly right. She had given him more options than one. You cannot say these 4 words unless you are trying to choose, right? And she had given him some information. He is pointing to the information. And he had understood it. He had really understood it. And he said, I prefer this one. She also had done something else, I think. She had created a lot of safety. This man felt safe to speak, right? I'm trying to do the same here. I want you to feel really safe to speak, right? I want you to work with me. So I want you to feel nothing is the wrong answer here, right? Okay? And I want to create what's called psychological safety. Have you heard this term, psychological safety? It's by a psychologist called Edmondson. And it's very important in the workplace, actually, that you feel safe to speak about something that is not quite right or you don't feel comfortable. Psychological safety is that principle. But it's very important in shared decision-making because patients need to feel very safe to speak. And they often do not feel safe because they are in a position of low power. They feel, oh, I'm in the presence of a big expert. Person has lots of information. My opinion doesn't count. Well, shared decision-making completely reverses that, right? So she had given him information. Her body language is quiet. She is also doing what clinicians and doctors find very hard to do. She stays quiet. She stays quiet because she has asked a question and she stops speaking. And she stops speaking for long enough to signal that she is waiting for an answer. And I don't know if you have recorded many clinical conversations, but pausing is often difficult for clinicians. They are under time pressure. They feel they have to go quickly. So they don't pause. They don't stop speaking very much. And so patients have a very hard time speaking. And in order to do shared decision-making, we need patients to speak. Which is why Sang-Hoon Hai had a talk with a journalist yesterday who asked lots of questions about how is it possible to do shared decision-making in 3 minutes? And I say, it's not very easy to do it in 3 minutes. Really not. One needs more time than that. I don't say you have to have an hour, but you need more than 3 minutes, right? So the structure of healthcare, the way we organize healthcare, I think may have to change a little bit if we want to be successful at this. All right. I have used 2 slides, my 2 most important slides. The only thing you have to remember is what this man said and what this clinician, the woman, did. It's all you need to remember, okay? Is it correct? Yeah, is it correct? Okay. All right, 1972. 10 years later from 1962. There's this guy. Well, actually, it was the time when somebody went to the moon and took this photo. This is Apollo 17. And I think this was the beginning of people beginning to worry about the planet. Right? When they saw this beautiful thing. Oh, that's where we live. Wow. Wow. So they began to worry about the planet. Oh, I'm sorry. Shall I do this? Okay. Maybe I stand still. Okay, is that better? Okay. Yeah, so they began to worry about the climate, but they also, this guy called Robert Veitch wrote this article. This is one of the first time I think the word shared decision-making was used in an academic article. His models are interesting. We don't really use those models now, but probably shared decision-making meets in the collegial model. But this is an important article in 1972. There was a guy called Katz, K-A-T-Z, who wrote The Silent World of the Patient and the Doctor, who in 1982 used this term shared decision-making as well. But I think this is one of the earliest examples of using the term shared decision-making in medical healthcare. (1997) now. Does anybody remember this phone? Who had one of these phones? Only me? Only me? Okay. This was made by Nokia in Finland. Now I have a Samsung. Nokia did not do well, right? They failed. But it was a very, very good phone, and you could text a little bit. Now we are, 30 years later, and amazing phones that we now have, right? But this was the transition to a phone that you could more or less put in your pocket. Before that, you had a brick you had to carry around. But it was also the year that Kathy Charles wrote this paper. She's a sociologist from Canada. She's died now recently. But this was a very important paper. It was published in the BMJ, had a nice title. It Takes Two to Tango, like dancing. She laid out some principles for shared decision-making. We can argue with some of those principles now, actually. I don't think they're completely correct, but it was a very important paper. I think this was the paper that began the interest in this field. Okay, let's go to much closer to our own days, 2025. A tough year, I think, for everybody in the world, right? A very tough year. I don't think this year is becoming any easier, but this one was a tough year. This is a scene from Gaza. Now, similar scenes now in Iran, I'm sure. But we are living in a very tough time. In this year, Paul Gudbrandsen, a guy from Norway, and I published this paper where we tried to summarize in ways that I think would be easy for clinicians to follow what the steps are in shared decision-making. So here's a try at a definition that I feel comfortable about. We need to blend science, really good information from scientific studies. We need to crystallize and summarize that for patients. We need to make it easy for them to understand science. We need to honor clinical experience. Clinical experience is something where you develop an understanding, an intuition, you've dealt with many patients and you know how to help them. That's really important as well. And then the third bit, which is what that woman did with that man. She asked and helped him express his preferences, his views. What was his priorities? How does he think some treatment is going to fit into his life and into his family's life? To do all these three things is to do shared decision-making. Michael Barry, a professor from Harvard, a clinician, said that shared decision-making is the pinnacle of patient-centered care. It's the best of patient-centered care. You cannot do better than this. If you are bringing science to people, good science, best science, if you're bringing your experience and also your kindness to people, and then you ask them, what do you think fits into your life? I don't think you can do any better than that as a clinician. And it's interesting, actually, patients also agree with that. That's exactly what they want. They want to be taken seriously, they want to be respected, and they want to know that you are acting in their best interest. But let me walk through some of the steps that I think is necessary. Maybe I can ask a question at this point. How many of you here consult or see patients? Who are clinicians in this room? How many? 1, 2. And the rest of you, you don't see patients. But you observe people being seen by clinicians, right? You observe it. It's interesting, right? Probably some clinicians got the message to come here, but they are probably busy. They are seeing patients. But the reason I am here, I think, is for you to understand that I would love you to understand these slides and to have them and to say, let me talk to clinicians about what I think it's like to do shared decision making. I want you to hear about this idea, and I want you to think about it carefully. Does it fit into your practice? So here's what I want you to tell them. You need to invite people to this process. People need to be told, please join me in working around the information and the ideas that I have about what might be good for you. People will not really ask you to share decisions with them. You need to invite them. And after you've invited them, you will need to support them because they will feel very anxious. Oh, I'm not used to this. This is not what most doctors do. This is not what most nurses do. I feel a little lost. So you will need to say to them, don't worry, I am going to support you. We're going to make a team together, you, your family, and I. We're going to make a team and we're going to figure out what is in your best interests. So support and invitation, absolutely critical. Patients do not want to be abandoned to make a tough decision on their own. I say to you, we have A and B. I give you a lot of information about A and B. And then I say, what do you want? And then you say to me, I don't know. I'm not sure. I'm confused. I've never heard about these two options before. I really don't want you to put all the responsibility on my shoulders. It's too hard, right? So do not abandon people to make difficult decisions on their own. When you have done this with a patient, maybe 3 or 4 or 5 times, and they say, oh, you're not such a funny clinician. You know what you're talking about, and you're helping me to make the right decision, then they might say those 4 words, I prefer this. But in the if this is your first time doing this, most patients will say, I don't trust this clinician. They don't know what they're doing. They're giving me choices. That's a very odd clinician. So you have to bring them with you and educate them to say, don't worry, I'm not going to abandon you. I'm going to help you make the right decision. So it's a process of engagement and support. Timothy Quill, the ethicist, some of you will know about his work, said, do not abandon patients. And here in Asia, South Korea being a wonderful example, the family is very important. Your relatives, your daughter, maybe son, very important to say, I've developed a cancer. I'm being offered treatment choices. I'm not sure what to do. The family will need to discuss. So that means you can't have all the family in the room. That means giving people time to talk to their relatives next to and so on. So a big decision that requires shared decision-making will need to involve other people. And that is also a challenge when you have to see people very quickly in short time intervals, right? You know about this. So this is a very big step, and it's a step that healthcare process and workflow doesn't recognize very well. I also think that this is a step that people are now writing about. I want to understand what's important to you as a person. And goals come at 3 levels. Imagine I have a headache. The headache is a problem for me because it really hurts. So I have a symptom goal, which is I want you to get rid of my headache. That's very basic. Most people tell the clinician, I have a headache, I want you to get rid of it, I want treatment. That's a very simple level goal. It's the symptom goal or the problem goal. But there's a slightly deeper problem to my headache because my headache means I can't do my work. I can't concentrate, can't finish what I was doing. So there's a functional goal. What does my headache stop me doing? So symptom, function. But then there's an even deeper goal. Because the reason I'm trying to do my work is to pass this exam that I have next week. In order to pass the exam, to get to a qualification, to get to my next job. So I have a life goal, which is to get a better job. So my headache is a problem for me on my life goal, my functional goal, can't do my work, and also my symptom goal. So goals are really quite complicated, right? And good clinicians know how to get to life goals, as well as functional goals, as well as symptom goals. So eliciting goals helps you put the right treatment in front of patients. And so now we come to information. And this is a very interesting issue right now because over the last 2 years, suddenly large language models have arrived. Claude, ChatGPT, Grok, whatever. And these tools are suddenly giving patients powerful tools to find new information. Patients definitely used to use Google before. Now they are turning to these large language models and AI to find information. So they will be coming, always be coming, with a lot of information in the back of their heads. And so the task of clinician is to say, I understand you've found already some information, maybe you haven't told me about it, but I also have access to information that is trustworthy from a scientific basis. And this new conversation needs to happen about, tell me what you already know. This is the kind of information I have access to as a clinician. Let's put them together and see if we can work out what are reasonable options for us to talk about. We are living in a very different world now because of these large language models. And clinicians have a tough job trying to pull it all together, right? There's no doubt. And maybe just one more thing before I finish with that side. Patients are not going to read academic papers about randomized control trials. They need information in videos or words that are very simple to understand. Maybe pictures. Maybe very little figures or numbers because their ability to understand statistics is limited. That's not their world. So we need to make this kind of scientific information easy for patients to understand. And it is possible. They may not understand it to the level of a scientist, but they can understand enough to say, this is what I prefer versus that, because of the side effects, because of the benefits. And then this most difficult step of all. I say to people, okay, now that you've understood, now that I've invited you, now that we've supported you to understand the information, what do you think? What do you prefer? Or do you have any more questions? And then I go quiet, because I'm waiting for the answer. If I only have 3 minutes or 5 minutes or 7 minutes, this is a big challenge, massive challenge. So I think we need to be very creative about how can we do these processes in the typical healthcare workflow. It's quite a few steps, right? It's quite a few steps. But I imagine that if you were a patient with a serious illness where there's more than one reasonable option, you would want to find a clinician who does this with you. In fact, I would almost say that you would pay extra to find a clinician to do this with you. You would want to find somebody who takes you seriously, who informs you, who invites you, who tells you what the science is all about, and helps you decide, yeah, this is best for me and my family. So the challenge we are facing in healthcare, US, UK, South Korea, wherever you live, is that this process doesn't really fit in what we've already built. And it's a challenge, and I have no easy solution to this. I'm not saying I'm here to give you a solution. What I am saying is that this is what good healthcare looks like. All of our challenge, it's a challenge for all of us, whichever country we're in, is to say, how can we make it work something similar to this? Then we need to bring senior clinicians who think, oh yeah, I agree with this process. We need leaders at the top of hospitals and top of healthcare systems to say, we agree with this. And then we need people at the policy level to say, how can we build something that's a little bit closer to this, that helps clinicians do this in a better way, with more time, with more respect for patients, whatever their level of literacy, whether they're not educated, whether they're immigrants, whether they are really poor, that we help them as much as we can to make good decisions that are in their best interests. All right, I've gone through what I think is shared decision making, right? I'm going to pause just for a little to see if there's any questions or pushback. Who wants to say, funny idea, bad idea? Anybody?
Glyn, is it just a small question?
Yes.
Seems like the order of items can be random or intentional, right? But I think you intentionally put the order of these things.
A little bit.
Is there any logic behind it?
Yeah, I think, first of all, the logic is that if you say to you, I'm going to invite you to tell me what you think about treatment A and treatment B, you say, oh, I'm not sure about that. You will worry. You will be anxious. You will feel responsibility. So I need to reassure you at the beginning that I'm going to help you. Second process is I need to give you information, good information that you understand. So that I cannot ask you to choose without giving you some understanding, right? And once I've given you understanding, I can go to the next step, is to say, do you have any questions? What are your views? So there's a slight of logic. There's a logic to it. Now, I don't think this has to fit into one visit. you can make it in more than one visit. And I think that might be important, actually, because you can get to the step where you've got trustworthy information, but that last step of deliberation, of talking, of discussing, that's when the family people need to come in. And they are not there in the room. They need to go home. So we need to break this logic up into steps, I think, especially for complicated decisions, where there's treatment for the rest of your life, or there's a very aggressive treatment with side effects and adverse events, like in aggressive chemotherapy, or very major surgery. I'm not suggesting that you have to do this for every single clinical decision. Sometimes there's a very obvious best thing to do, right? But there are many decisions in healthcare that fit into this category. Yes.
Thanks for sharing very important principle for decision making. I wonder, in this principle, you found some cultural difference, because Western culture autonomy is very important, but in Korean culture, sometimes patients or people, they prefer some, just they want doctor give them best option. Yeah.
I think there are cultural issues, absolutely. But I sometimes think that these cultural issues are changing, even in places like South Korea. Young people want more autonomy, right? Is that true? You agree with me? Okay. Young people are more assertive. They ask more questions. They don't want to be told what to do. So I think even in Asian cultures, or cultures where there's more of a family decision-making process or more respect for expertise, I think that's changing. Not only because of the cultural change or a cohort effect where young people are asking more questions, but also the technology we now have. It's changing people so quickly, right? We see that. So yes, there are some cultural, and this is where a skilled clinician can be good, right? Okay, so you don't want to make a decision. I understand. I will help you. I will guide you. But I will understand you as a person before I guide you. Do you see what I mean? There's a bit difference. Okay. All right, so that's the logic, and those are the issues. This was the paper. We involved a lot of clinicians in this paper, actually. So we tried to involve a lot of people, plus patients, in this paper. There is a simpler version of this model, right? The 3-talk model. And I use this for teaching clinicians. And in fact, one of my colleagues in Texas put this poster on a wall in the emergency department. And he told his doctors, hey, I heard this idea about the 3-talk model, and he did it in the emergency department. And he said, I want you to try this with patients. And I said, what? In the emergency department, really? And he said, yes. And so one of the doctors said to him, hey, Lane, this is the name of the guy who wanted to put the poster up, I already do this. Why are you telling me to do this? I already do this. And so Lane said to him, okay, good. I'm happy that you're doing it. And he asked him one more question. He said, do your patients know that you are doing it? Are you explicit about it? Do you tell your patients that you are going to work as a team, give them options, and ask their views? And the doctor said, no, I don't think they know that. So he said, well, try that. Tell your patients that you are doing it. So he didn't argue with him. He just said, tell your patients that you are doing this 3-step process. And actually, he tried it, and he said, oh, it made a difference, actually. It made a difference. Now my patients feel a little happier with me. They're more satisfied. So this is a much simpler version of that other paper. But I think when you are in a busy clinical situation, or you are teaching medical students or early residents, This model is simpler and a little easier, right? Just follow these 3 steps, try it. But the important thing is make sure you tell your patients that you are doing it. Not just do it, tell your patients you are doing it. Okay, so, it's 10 o'clock almost. I have only a few minutes left, so I have to be careful. So now I want to say, does anybody benefit from this process? Who benefits? Who do you think benefits? I've asked many questions now. I think you're ready to answer me. Who benefits? Patients and clinicians both. Yeah, it's a clever answer. Anybody else? Okay. Well, let's run through a few slides quickly. Who benefits according to the research so far? There's a big impact on patients. When you do this and you do it well, you don't put pressure on people or big responsibility. You do it well, you do it skillfully. Patients really like it. The satisfaction levels is like through the roof. There's a hospital in Denmark that I know in Vejle, and I think you visited there, I think. Karina Dahl Steffensen, she's now the dean of a medical school in Denmark, and I think Sang Ho visited that place. Their patient satisfaction level, because they've been doing this for 10 years, is the highest in Denmark. They were high before, but it's even higher now. So we know that patients feel very happy with this approach. So, these are some papers. I'm not going to go through those papers, but for every statement I'm going to make, I'm going to point you to some papers. And these are not all the papers. People's knowledge about risk increases. So patients get to know, maybe there's a bad effect that will happen, the adverse effect, the side effect. They know. They get to know. And so that means when the bad thing happens, they're not that surprised. They already knew. And that helps in many ways, which I will come to. What about these tools that can help patients understand the comparison between options? These are tools that I licensed to a company that are making quite a few of them, but basically they are tables that compare. Option A, option B, option C, and a few simple questions about how to compare them. Like you would compare a washing machine or a car. What's the best feature for safety, and so on and so on. Basically, it's a well-known product for comparing things and deciding what you like. So we know from these tools, and I mentioned this Cochrane systematic review that I'm sure you all know, 209 trials now showing that patients' knowledge increase, their risk understanding increases, right? It's very clear. And this is one of the important things. Patients, when bad things happen, they regret having chosen that treatment. They really, well, why didn't I know this could happen to me? And so if you do shared decision-making well, you create immunity. You make people say, oh, okay, I kind of knew this bad thing was going to happen, and I don't feel so bad. I don't feel so much regret. Thank you, Sang Ho, for telling me that this might happen to me. Immunity against regret. These are some papers about this issue. We know that when you do this well, you increase trust. And increasing trust reduces anxiety. A few more papers showing this. We know that in some situations, and this work is only just emerging, in particular it works for asthma, a self-managed disease where you use the right inhaler in the right way, it improves individual outcomes. it also improves, in some situations, levels at the population, outcomes at the population level. I don't think this is a blockbuster outcome issue. In other words, it's not massive improved outcomes. And if you think about it, I'm not sure you would expect massively improved outcomes, because you are dealing with two options where the difference between the outcomes are not massive already. Option A and option B are competing with one another. Option A has a few benefits, but option B also has a few benefits, and they all also have risks. So the difference between A and B on a clinical trial, a randomized trial, is not that big, 5%, 10%. In clinical trials, A is slightly better than B, maybe. But if you give A and B choices to patients, and some of them go A and some of them go B according to their preference, you are not going to predict massive change in outcomes, because they will vary what they choose. So the issue of improved population level outcomes is not something that we need to worry too much about. If option A and option B are reasonable choices, then we don't worry which way the patient goes, A or B, right? So the logic is probably on the average, the outcomes will be better, but let's not worry too much about that. Here are some examples where shared decision-making has improved clinical outcomes. In some situations, shared decision-making leads to cost reductions, particularly where there's over-treatment. And this has been shown particularly in countries like America, where the rate of intervention or surgery is very high. People having knee surgery at very young ages for minimal disease. So in this situation, patients say, maybe I will wait before having the operation, before having a new shoulder or a new hip or whatever. So in situations where there's a lot of over-treatment, then I think shared decision-making can lead to cost reductions. But I don't think anybody in the field is arguing that the reason that you should do shared decision-making is to bring costs down. It's not a good argument. Patients would not want that. So I don't put this forward as the reason for doing shared decision-making. There are other much more important reasons, like ethical issues. And actually, there's a debate. These papers are saying the evidence for cost reduction is not that good or not that high. However, I think if you do this well, people are more satisfied, they complain less, and they go to the lawyers less. Right? It stands to logic. Oh, you already told me that this bad thing can happen? Okay, fair enough. And you put it down in writing on your notes. Even if I go to a lawyer, you were not negligent. So the lawyers have no place to go. So this is important, and particularly in societies, we live on lawyers going after clinicians or after hospitals. I don't know what it's like in South Korea. But this is a big issue. Doing this well and documenting it well reduces legal risk. And we have some data about that. I'm so interested that you mentioned clinicians, because this is a relatively new finding. Relatively new. Who else benefits? I think it's very important at the time we are now in to know that clinicians benefit, actually. And I want to show this study, which I think I published last year. I want to go through it in a little bit more detail to you. I interviewed 24 doctors, not a very high number. I did semi-structured interviews, a qualitative research study with 24 doctors. But I chose them very carefully. They were all in clinical practice. They were seeing patients. I noticed some white coats here, so I think maybe you are seeing patients. Is that right? So these people were all seeing patients. They were all advocates or champions of shared decision-making. They had understood it, they were doing it, and they were teaching it to their residents and other people. So they were really champions. They believed in this approach, right? And they'd been doing it for quite a bit. They'd been in practice on average about 10 years. So these were experienced clinicians that they were doing shared decision-making day in, day out. So we interviewed them. There were 12 in North America, 10 in Europe, 1 in South America, and only 1 in Asia. It was 1 in Taiwan. I wish I would have done somebody here in South Korea. But you have an opportunity to repeat this study, actually. So think about that. They worked in different branches of medicine, all these different areas. They were not just family doctors. And to a person, this is what we found. They said that doing shared decision-making gave them professional fulfillment. They felt better as clinicians when they did this. I think that's very important. They said they were at less risk of moral injury. I hope you have heard about the term moral injury. If you haven't, look it up. It comes from people being at war, fighting, killing other people, and feeling, this is against my ethical principles, but I have to do it. It's my job. I'm in the army. But they damage themselves. When they come back from the war, they have PTSD, and they feel damaged, right? Feel really damaged. So clinicians were saying, we feel this sometimes when we are working so quickly. We don't have time to get to know our patients. We feel bad about working in this way. And you know this problem? Burnout. Do you have a burnout problem in South Korea, clinicians? I noticed some heads nodding. Yeah, it's the same all over the world, right? Same everywhere. So if I am at less risk of moral injury and less risk of burnout, this is an extremely important finding. They may probably take more time with their patients, but they benefit in their heart, right? In their feelings. So when we have, in the last 2 decades, 20 years, been telling doctors, you should do shared decision-making because your patients will like it, they say, yeah, okay. Maybe they will. But I'm seeing patients too quickly. I don't think my patients want it. So they push back and say, I'm not interested. And you will find the same. You go and talk to the clinicians here in South Korea, they say, good idea, not for me. But I think a better way to say to them is, and to their managers at the hospital level, and to the policymakers of the government to say, if you do this and you do it well, you will have a better workforce. And if you have a better workforce, your patients will be happier. Your health system will be much higher quality. So I'm getting to the feeling that I am so sorry that I didn't do this study many years earlier, right? Because this evidence is not available to us. They also said, I tell my nurses and administrators that I'm doing this, and you know what? It creates a better team. I give these tools that I'm using with patients, the patient decision aids, I give them to my team members and say, this is what I'm doing with my patients. Can you please reinforce it? Use the same tool so that we're on the same page. We are telling the patients the same thing about these treatment options. And you know what? It creates a better culture in that department. Yeah, so these are the results. Because when I share a decision with you, we have a shared responsibility. Even if a bad thing happens, I know that you knew that bad thing. I don't feel so bad myself, and you have some immunity against that because you helped choose it. All right, so just to summarize then, patients benefit. No argument, I think. What we're beginning to find is that professionals, nurses, OTs, physiotherapists, clinicians. And here's where we do not have any evidence yet, but I think it should come. Organizations. This is where the money gets spent, right? The budget for your hospital here is probably millions, maybe even billions. Imagine if all those things in the yellow side begin to become better. Less time off, less burnout, less complaints. Just imagine the return on investment that would generate. How do we get this done? Well, I want to go quickly now because it's probably time for... Oh, yes. Thank you, Minji. I want to go quickly now. This is a book by a professor who works with me in Dartmouth, Ron Adner. I've only recently read this book, but he talks about what does it take to do an innovation, to get something new into practice. This is pretty complicated, and I'm working on trying to write this paper right now. And I'm going to go quickly. But he says that when you bring anything new into an organization, there's something called co-innovation risk. Other people need to change as well. It's not just you. And there's also an adoption chain risk. How many people have to say yes before something happens in an organization? That's called the adoption chain risk. And the problem with this adoption chain risk is you have 1, 2, 3, 4 people who need to say yes. If one of them says no, it stops. So you need all of them to say yes. That's the adoption chain problem. And if you read his book, he'll go into more detail about this. And I think this is the problem we're facing when we're trying to bring shared decision-making into organizations. We need changes on payments, patient information tools. The electronic health record is not ready for this. Training, forecasting and modeling all the benefits that could come to organizations. None of that is really in place, right? Not really. And then there's the adoption chain risk. All of this has to happen. System leaders need to say yes. Clinical educators need to say yes. Clinicians, the biggest block of all, need to say yes. All of them need to say, okay, let's do this. And then patients need to be receptive to it. I don't think that's such a problem if you have skilled clinicians. But there's quite a few people that need to say yes along that chain. So this is a work in progress. I haven't finished this yet, but I think this is important at the policy level, right? Can we measure it? All right, I've got a last quiz for you. I want to measure shared decision-making here in this room right now. Who here has been to see a clinician in the last couple of years? Who? Have you seen a doctor or healthcare professional in the last 2 years? I have. Who else? I'm not going to ask you any personal questions, don't worry. All right. Do you know that any of the family members who've been to see a doctor recently? Yeah? So I'm going to ask you to answer 3 quick questions. Here they are. As you leave that clinical visit that you just had in the last 2 years, somebody asked you a question on a pad or on a phone. and they ask you this question: how much effort was made during the visit to help you understand your health issues? If 0 effort was made, you score 0. If maximum effort was made to help you understand, you score 9, or somewhere in between. Can you score it right now? Memorize the number in your head. You done? All done? Okay, good. Next question. How much effort was made to listen to the things that matter most to you about your health issues? Same scale. No, they weren't interested. No listening going on. Or, yes, they listened very, very well. Couldn't do better. Score 9. Could you score that right now? Okay. Next question and final question. How much effort was made to include what matters most to you in choosing what was to do next? 0 or 9, very best. 0. All right, so add them up. Add up the scores that you have. The maximum possible score is 27, all right? Has anybody in the room got a score of 27? Put your hand up, please, if you have a score of 27. Can you look around? See who's got a score of 27. I think that is 0. Is that correct? Okay. Well, you're pretty tough. Pretty tough on your clinicians. You don't give them high scores here. So let me ask you, if you were 100 patients in South Korea, and now I say, behave like patients and score these measures, how many people out of 100 patients, the percentage, would give a score of 27? Your score was 0% in this room. Now I want you to imagine you to be a patient leaving the visit. What percentage of the 100 people would give 27 in your view? 30%. Anybody else? Who was 9 or 90? 90. 90. You are a very interesting person. No, really.
Because hello everyone. Oh my God, yes, it is really a surprise to me. My name is Haesun, and I got PhD in communication field. So I'm not physician or clinician. Yes, so to be honest, I scored 25 for your Q3 questions. Yes, so I thought that, well, if I score 25 or the other people can score, yes. So
Yeah.
yes.
So that's very interesting, actually. How many people got close to 27? 26? Anybody? 25? You are 25. Yeah. So you are very generous. You are very generous. 24, 23, 22, 21. Okay, 21, 20, 19? 19 there. So, okay. Most of you are lower than 20, right? So you are very generous, 25. So I asked the question, and you are actually the closest. 30 was okay. 90 is closer, because the real answer is 64%. When you ask this to patients, on average, 64% of patients give 27. Here you all said 0, right? So what does it say about our patients? They are like you. They are generous. They're very generous. they score very highly. They're very forgiving, right? They're very forgiving. But here's the good news. We do have a range of scores. For any particular clinician, it can go down as low as 40, or it can go up to 90 for some clinicians who do a good job at these three things of giving information, of listening, or including your preferences. Some people are better than others. So we are beginning to be able, at the patient level, at least something close to these three items, right? Okay. So this is the Collaborate score, maybe you've heard about. And so we've used this in many different systems to measure from the patient side of things whether they feel they've been involved in shared decision-making. And it's a good rough estimate of what's going on. But a better estimate, in my view, is to record and to analyze the recording, to do something on the observer side. But that's much more work, right? Much more work. Okay. So this is another measure of Considerate. This is about people at the end of life. I'm going to go very quickly now. I'm not going to ask you to do those. I'm also asking clinicians how willing they are to do shared decision-making. This is the Incorporate score, and this is the Integrate score for a measure of care coordination. If you're interested in any of these things, just email me, right? I'm not going to dwell on these at the moment. And we have a conference about this in Dartmouth in 2026. I hope to see some of you there. It'd be lovely to see you there. All right, and this is the book. If you want to dig into more details, get the book. All right, so that's me, and I'm finished now, so I'm ready to take questions. We have about 10 minutes. I'm sorry that I've taken a bit more time than usual. I normally try and finish 40 minutes, but I wanted to go slowly and to understand your points of view about these issues. So thank you very much. Yes, please go ahead and ask questions.
Thank you very much for your presentation and lecture. I also fully agree with the benefits for both of us and patients, and also I agree that our cultural difference will be changed soon. But now I have to meet my patient even in today. When I invite my patient to share decision making, many of my patients are embarrassed about this situation, and also sometimes some patients are angry at me.
Yes.
Because they want for me decide for everything for them. If you were in my shoes, how will you managing the patients, the persuading or giving up the patient or modifying your protocol?
I appreciate your question very much. Over time, your patients will change. They will get easier. It will get easier for you. But at the moment, I think it's perfectly normal for patients to say, you decide for me. Tell me what to do. Perfectly normal. Because they fear being abandoned to make a difficult decision on their own, right? They really worry about that. So in cultures where there's less agency, less autonomy, this is exactly what we find. We also find it in other countries, UK, United States. So my suggestion for you is, I'm happy to make a decision to help you. But first of all, I want to know a little bit more about you. What are your goals? What really would you like me to achieve with the decision we're going to make? You're an orthodontist, right? Is that right? A dentist.
No, the dentist.
Dentist. So are we reducing pain? Are we keeping your teeth? Are we keeping your dental health for the future? What is it that's really most important for you? Let me understand that, and then I will try to make the best decision so that we can achieve that goal. And then at least you've understood your patients and what they think their preference are and what's most important to them. And then I'm going to say, okay, in your situation, I think this is the best decision. We could do the other one, but I think this is the best decision. It will probably lead to this outcome. Do you agree with me that this is the best way? Or do you think the other one is the best way? So you check, right? You make a decision or you make a recommendation and you check and say, given what I already know about you, I think this is best, but do you agree? I think they will say, okay, I agree with that. Or they might say, I'm not sure. What do you think of this approach?
Yeah, I'd like that. I really love your the modification.
You like it?
Yeah.
Try it.
Yeah. Yes. I just asking about the. Can I modify your protocol? Yes.
Yes, of course. But what I mean, you don't have to modify it. The non-abandonment is what I just did. That is non-abandonment, because I become curious about your goals, and then I don't abandon you to make a tough decision on your own. I don't need to modify my protocol. It's just, I did already know your preference because I checked with you, right? I checked what was important for you. So it's a very small modification. Yeah. Other questions? Yeah. It's 90%.
Hello, Dr. Glyn, but my name is Hae-sun. Yeah. It's good to see you, and thanks for your interesting this key speech. Well, do you have an experience for collaborative work or combining with communication scholar or communication expertise? Because sometimes I think that the communication scholar, including me, can contribute to understand patient language or patient perspective. But as you know, I couldn't, or it feels too difficult to find example or the other samples for collaborative work with medical public health and communication field. So do you have a experience about it?
Not too much. I mean, there is a field in healthcare of communication skills training, right? For clinicians, nurses, medical students, and so on. So there are courses in the curriculum for communication skills training. But I think you're talking about communication at a wider level. Is that right? So I think the university here should really say, please come work with us. Because I think we need to work at the public level as well. You already hear that patients are saying, I don't feel comfortable, I feel anxious, well, you're a funny doctor, I don't want this. So I think we could work at the public level to say, it's okay to ask questions, it's okay to express your views, or to say this, when you've been to the large language model or Google or whatever, to say, I've done my homework, it's okay to ask questions to the clinicians. So I think the public attitude towards healthcare could also change. And that could be helped by the media, newspapers, YouTube channel. In fact, Hangso took me to, was it a YouTube channel yesterday? Yes. After the rain or something like this. So I think it's possible to do work on a collaborative nature between communication skills or communication studies and healthcare. I think people here would welcome that. So I hope you have plenty of cards.
Thank you.
Yes, Yuri.
Thank you for your wonderful lecture. I have a question for the patient's preference. Could you explain a little bit more about what kind of preferences that the clinicians should consider, or what kind of the boundaries about the preference you mean?
Okay. So this gets down to, we haven't had the question yet. Do you have to do this for every kind of decision, right? Or are there decisions where this is more important? So I come to that kind of tangent on your question. I think there are clinical topics or conditions where the patient's preference really matters, right? Whether they want something with a high patient burden, lots of work for the patients, or low patient burden, not so much work for the patients. In type 2 diabetes, for example, this would be a good example. Do you want to go towards insulin when your blood glucose is not under good control? Do you want to take on the role of learning about how to use insulin and all the dangers of using insulin in your family and so on? Or do you want to stick with more medication? Or do you even want to really focus on your diet? So these would be patient relevant issues, patient preference issues, even family preference issues, right? Because in diabetes, not just the patient that has to change the way the family is buying food or cooking food or giving food has to change as well. So in that situation, there are really practical things that matter. And it's those kinds of learning how you live your life that will determine what best fits into your decision-making process. So that's what I mean by patient preference. Some people like to take a lot of risk. Some people say, I don't want to take risk at all. Some people say, I am willing to tolerate that side effect. And other people say, nah, I don't want nausea. I don't want to lose my hair. I don't want 2 extra weeks of life with this aggressive chemotherapy. I would rather have comfort care in a nursing home and die peacefully, right? So these are really tough decisions at the end of life that are preference sensitive. They're sensitive to what really matters to you. Is it quality of life or quantity of life? And at the end of life, patients have really strong views about this. That's a difficult topic, I know. But many of you here maybe are in nursing. You meet people who are struggling with low quality of life, maybe in ICU, where maybe the family is not quite sure this is the best thing for them. So that's what I mean by preference. Does that help?
Yeah.
Okay. Questions?
Thank you for your lecture. I'm Eun-kyung from National Cancer Center. I'm endocrinologist treating the thyroid cancer.
Yes.
Last year, American Thyroid Association published a clinical guideline which contains shared decision making very frequently. So I was wondering if there is currently any specific policies or campaigns regarding SDM within the oncology field in the North America.
In the oncology field in North America?
Yeah.
Okay. Well, the short answer is yes. I'm sure there would be. Absolutely. Do I know the detail? No, I don't. I would happy to help you though, because this area of cancer treatment is really interesting. The developments about adjuvant chemotherapy and neoadjuvant chemotherapy and all the possibilities now for lung cancer, for example. There's a lot of interest in lung cancer treatment where you do chemotherapy before surgery. I know that's not your field. You're in thyroid, right?
Cancer.
Thyroid, yeah. So absolutely, there's a lot of interest about how much choice do we give, first of all, and how do we give those choices to patients. So it's an expanding field. And as you know, in oncology, there are so many new treatments. Is it CAR T cells? This technology is really quite revolutionary, right? And intervening in a different way at a different step. So absolutely. If you should probably happy to try and help connect you. There are some people I know in my college in Dartmouth who are interested in thyroid cancer, because one of the challenges there is the early diagnosis, right? Is it really a cancer or not, right?
Yeah. But it is not limited to the early stage of thyroid cancer. And it expanded to the systemic therapy for the advanced thyroid cancer as well. So they are focusing on the choosing the drugs. Yeah, it can be helpful for the shared decision making to implement it in the oncology field. I think.
Yeah, absolutely. But I haven't really mentioned a lot about these tools that help patients compare treatments. But I think they're quite important. And one way, and I didn't mention it so far, one way to help reduce the amount of time this takes in a visit is to say, patient, you have this diagnosis. Let's give you a tool to compare the treatments before the visit so that you maybe have an admin person or a receptionist or a coach, maybe even a nurse to say, let's understand the treatment choices in front of you. And then you go and see the clinician and say, okay, now that you've understood the choices, what are your views? What are your preferences? What do you want to do? So the process of getting that really time-consuming information exchange, doing that before the visit or before the next visit, that can reduce the amount of time it takes in any particular visit. So the creation of those tools can be a step that communication people can help, absolutely. Communication designers can help. But also there are companies out there making these kind of tools and trying to update them. But it's an expensive business to make readable tools that are easy for patients to understand, that are still scientifically accurate. That's the challenge, right? Yes.
Okay, thank you for your presentation. I read many of your articles that you presented today, and it was very interesting because I read the article from my perspective of you, but it was the summary from you, and I know better about your perspective. So it was very interesting. Thank you. My question is that, I can't remember very well, but there is a article in 2025 about the clinicians, the recommendation or something like that. And you recommend that deliberation phase is recommended with the other consultation. Am I correct?
Mm-hmm.
Yes.
If it helps.
If it helps.
It helps if you
Yes.
can possibly arrange it.
But I'm not sure you asked whether you heard about it. We have a 3 minutes consultation in Korea. I mean, it doesn't be made from clinicians that, I don't know, clinician want to faster consultation. It's not like that. It's just system and I don't know, the national insurance system and all. It's complicated, but at the end, maybe they can extend 2 minutes or 3 minutes more, 6 minutes consultation or something like that. But at the end, it's very hard to split the consultation with 2 or more. So the question is the sustainability. So
sure.
If it is health and if it is very important in SDM, what do you think the most important thing that we can adjust or adopt it in our country to sustain the shared decision making?
Right. Change the system.
I be the president or Sango will be the president and yes.
But it's not just your country, honestly. It's not just your country. Every health system has a problem with this, honestly. And that's why I find myself a bit frustrated sometimes, right? Because we know that this is a reasonable process, right? It's a human, it's good for humans to do this process. But the health system has been designed in such a way that it doesn't really allow this to happen, not in a good way. So although I generate a bit of laughter, I'm really quite serious that we need to change the system. In the US, they spend, I think, 18% of gross domestic product, GDP, gross domestic product, on healthcare. The outcomes are worse than yours. You have better outcomes here. You spend around 10%, I think, roughly. UK spends 9-10%, Europe, Germany a little more, but nobody spends as much as the United States. The reason they spend so much money is that they have so much administration, healthcare management. It's not because they spend the money on clinicians. And so the system in every country, I think, has a struggle to do high quality patient care. Now, you know, should I stop saying this is a good system, this is a good process? I don't think so. I think this is the better process, that if the patients had the vote to say, design me a system to deliver this, they would do that. And they may worry about the cost. But I think it's more about the design of health systems and the policy level to say, maybe there's a return on investment. If we do this process well, then we don't spend so much on other things, administration, on lawyers, on recruiting new people and training new people because they're burning out. Maybe we are better off. But this is such a big problem, honestly. The question you've just asked is a question for every health system, not just South Korea. Maybe its time here is very short, but it's similar in many countries, right? So I don't know if there's a health policy person in the room or a politician in the room, but I would ask them to talk to clinical leaders to say, let's design a different system where we give patients and clinicians a little bit more time to do this process. I think it should be possible. There's a lot of waste. And I think if we try to reduce the waste and do more of this, I think we would have a better clinical workforce and happier patients. Thank you for your question.
Thank you for your answer.
And then I will be on the next plane out. All right. Oh, another hand goes up. I'm happy to answer questions, but I want to respect the time you have for other things.
It'll be a quick question.
Yeah, sure.
It's really nice hearing you today because we reference your work so much in what we do too. My question is from a clinician's perspective. So your work discusses a lot about equipoise decision making.
Yeah.
And when we have two options, let's say A and B that both meet clinical standards.
Yeah.
And we personally have a preference, right?
Sure,
for whatever
course.
reason. It could be for production expectation,
Sure.
cost,
Sure.
and some for patient benefit as well.
Sure.
How should a clinician shape their mindset
Mm-hmm.
so that they could handle that situation without unintentionally
Sure.
putting their own agenda?
Sure.
It's more about the shaping of the mindset because you could unintentionally persuade the patient to go a certain direction, right?
No, absolutely. You're
Thank
absolutely right. And to be honest with you, it's impossible probably for clinicians to be completely balanced, right? They have a view and say, I think this is best. One of the things to try and do is to not make your recommendations until you've described the options in a balanced way, right? As balanced as possible. And then to do that kind of preference elicitation step to say, hey, Sang-ho, I've given you two options now. I'm really interested in, do you have any more questions or are you leaning in one way or the other? So let me hear your views before I maybe make my statement about. Because if Sang-ho says to me, I'm still confused, tell me what to do. And then maybe I need to say, all right, I hear that you want me to guide you. Is that correct? You want me to guide you? And he says, yes, I'm still confused. Okay. And say, Sang-ho, I know that this about you and I know this about you. Given that I know that about you, just like the dentist, I think this is probably what would be best for you. But I want to check with you whether you disagree or you agree with me. So you keep your recommendations until later. Right? You keep them until quite late in the process. Clinicians are not going to not have an opinion. And typically, most clinicians want to do the very best thing for their patients. So they don't want to recommend something that is bad for patients. So there's a level of trust there that I think we should accept. But the process of eliciting people's preferences should help most clinicians go in the right direction, I think. Perfect equipoise, I don't think it exists. Not perfect, yeah. All right. It's 10:42, winding up. All right, thank you. Thank you very much for your questions and for your time.